All right, today we're going to do a complete visual walkthrough of pediatric HIV pathophysiology. The whole point here is to build a really clear, step-by-step mental picture of how this virus works in kids. This is exactly what you need to visualize the process and really lock in these concepts for your exams. So, let's dive right in. So, here's the big question we're tackling today. How can one tiny virus bring down the body's entire defense system, especially in our youngest, most vulnerable patients? We're going to trace this whole journey from the moment the virus enters the body to the impact it has, and, most importantly, how we as nurses can step in and make a difference. Understanding this full picture is absolutely key. All right, so here's our game plan. First, we'll get to know the virus itself. Then, we'll see exactly how it pulls off this incredible hijacking of the immune system. After that, we'll follow the breakdown from HIV to AIDS, look at the very real physical impact, and then wrap it all up with our nursing interventions. It's a super logical path: cause, effect, and then action. Okay, let's kick things off with Section 1, the virus. Before we get into the nitty-gritty, we need to define our terms and really understand how this virus gets transmitted in kids specifically. First things first, let's get this relationship straight. HIV, that's the human immunodeficiency virus, is the actual infectious agent. It's the cause. AIDS, on the other hand, acquired immunodeficiency syndrome, is the condition that happens because of the damage HIV does. So just think of it like this. HIV is the burglar, and AIDS is the house being completely ransacked. So the big question is, how do kids get HIV? Well, the number one way, by far, is what we call vertical transmission. This happens during pregnancy, birth, or breastfeeding, going from an infected parent to their baby. Now, horizontal transmission can also happen through sexual contact or exposure to infected fluids like blood or human milk. Knowing these routes is just foundational for all our patient education and prevention efforts. Okay, that brings us to our next section, the hijacking. We know what the virus is, and we know how it's transmitted. But now, this is where we get into the really fascinating and kind of scary part, exactly how it wages war on the body from the inside out. So, HIV is a smart and sinister virus. It doesn't just attack randomly. No, it has a very specific target, the CD4 plus T cells. You've got to think of these cells as the generals of the immune system's army. They're the command center, the ones calling the shots and coordinating the entire immune response. But here's the thing. The virus's main mission isn't just to kill these generals. It's way more clever than that. Its goal is to invade them, get inside, and hijack their internal machinery to do one thing and one thing only: make more and more copies of itself. And the results? Well, those hijacked CD4 plus T cells, or generals, are turned into tiny little virus-making factories. As more virus gets turned out, more T cells are destroyed, and the count of these crucial generals just plummets. And as you can imagine, when you lose your generals, the whole army starts to crumble. This leads directly to a total, systematic breakdown of the immune system. And that crumbling army brings us right to our next section, the breakdown from HIV to AIDS. This internal collapse has very real clinical consequences. So here, we're going to look at how we diagnose the infection and, just as importantly, how we measure the damage to track the disease. Okay, listen up, because this is a huge, high-yield topic for your exams. You have to know why we use different tests for babies versus older kids. See, a baby under 18 months old still has its parents' antibodies floating around. So if we use a standard antibody test like an ELISA, you're almost guaranteed to get a false positive. That's why for infants, we have to use tests like PCR that look for the virus itself. Then, after 18 months, those maternal antibodies are gone, and we can switch to the reliable antibody tests. Now, how do we actually measure the damage to the immune system? We count those CD4 plus cells, our generals. But here's the catch with kids. What's considered a normal count changes as they get older. An infant has way more of these cells than a 10-year-old. And that's why the definition of severe immunosuppression is totally age-adjusted. You can see it's less than 750 for a baby, but it drops all the way to less than 200 for a child over 6. A really critical detail for pediatric care. Okay, on to Section 4, the impact. We've seen the battle happening on the inside. Now let's talk about what that looks like on the outside. We're connecting that internal breakdown to the external signs, symptoms, and the really serious risks you'll be assessing for as a nurse. This quote right here gets to the heart of the danger. Think about it. The body's security system is down. The generals are gone. This means that germs that are normally harmless, stuff you and I fight off without even noticing, can now sneak in and cause absolute chaos. These are what we call opportunistic infections, and they are, without a doubt, the biggest threat to a child with HIV. All right, if there's one opportunistic infection you need to memorize for your exams, it's this one: pneumocystis jirovecii pneumonia, or PJP. It is the #1 offender. It's so common, in fact, that it often shows up between 3 and 6 months of age, a time when the baby's HIV status might not even be known yet. So, what are the red flags you'll be looking for during your assessment? Well, things like failure to thrive or weight loss, oral thrush that just won't go away, chronic diarrhea, swollen lymph nodes. These aren't just random symptoms. Each one tells a story about that internal collapse. They're the direct result of the body just not being able to fight off even the most minor things anymore. Now, when the immune system gets severely weakened, certain conditions are so serious that they act as a clinical marker. They officially mark the transition to a diagnosis of AIDS. And you can see our old friend PJP is right there at the top of the list, along with things like wasting syndrome and HIV encephalopathy, which is when the virus actually starts to affect the brain. This is the point where the damage has become truly critical. All right, we've gone through the tough part. We've seen the virus, the hijacking, the breakdown, but now let's talk about how we fight back. This brings us to our final section, the intervention and nursing management. We're shifting from the problem to the solution. Our game plan has 4 main goals. It's a multi-pronged attack. First, we go on offense. We suppress the virus itself with antiretroviral medications to stop it from making copies. Second, we play defense. We use prophylaxis, preventative meds, to stop those nasty opportunistic infections before they can even start. Third, we build the body back up with excellent nutritional support. Think high calorie, high protein. And finally, we manage any symptoms to give the child the absolute best quality of life we can. And this right here is what you need to drill into caregivers' minds. These are exam must-knows. Basic infection control, like constant hand washing, is everything. The caregivers need to become experts at spotting the very first signs of an infection. Immunizations are crucial, but, and this is a big but, only inactivated vaccines can be used. Nutrition is a pillar of their care, and notice this last one, it's super specific. Body fluid spills have to be cleaned with a 10-to-1 water-to-bleach solution to actually kill the virus. So there you have it. We've traced the entire journey, from a single virus hijacking a single cell all the way to comprehensive nursing care. The big takeaway here isn't just about memorizing facts. It's about understanding the why behind every single symptom, every lab value, and every intervention. That's what transforms you from a good nurse into a true patient advocate. So the question to leave you with is this: how are you going to use this knowledge to empower, educate, and protect the vulnerable kids and families in your care?